Assalamu alaikum, dear all. Today's session of that ECG is about certain very important things that as you have gone through different ECG waveforms, different sessions earlier where we studied multiple things. Now, the most important thing is as you are going to interpret ECG, as you get hold of that ECG paper, you just immediately jump to abnormalities there. And that's the basic issue. That way you forget the basic principles that how to interpret ECG, and you may miss few very important and relevant findings. You may miss few marks, and you basically won't be getting the full marks in exams if you won't be following that order. Following that order gives you lot of clues where you can pick a patient is having tachycardia. He might be having rate of 110, but one of the candidate was only able to pick ST elevation because he found that big abnormality and started focusing on that abnormality only, and as a result he couldn't reach to the diagnosis as well as the relevant important findings. So please follow this basic principle whenever you are having ECG strip in your hand. And this basic principle is you need to focus on the paper speed and voltage first. This is so relevant and important because if there is some abnormality in the paper speed and voltage, the ECG, you won't be able to interpret the ECG the right way. Then start writing down your findings like first rate, then rhythm. We have discussed arrhythmias in detail. Then axis. I have told you about the axis earlier as well, that we will be using two rules. One is the thumb rule and the other one is paper method. Then PR interval. From the start of P wave to the start of R wave, we call it PR interval. And then ST segment, T wave, Q wave, which we have discussed in the previous session, QT interval. And similarly, then few miscellaneous things, including U waves, including electrolyte abnormalities. Then there are a lot of other unusual things which are beyond the scope of this lecture. And at your level, at undergraduates level, usually the medical residents, they are not supposed to look for those in-depth details, but it's basically the cardiologist job that they should be seeing those in-depth ECGs. And obviously we'll be focusing on blocks as well. So I mention it separately or I mention it with PR intervals so that that thing will remain in your mind, that what are different blocks. Now to start with, first thing is paper speed. It is important that whenever you see this ECG, you hold that ECG strip, you must be having a good understanding that there is a large square. Large square comprises of 5 boxes. And then this is a large square. And then there is small square. Small square is this small box. This is what you call small square. So this ECG paper is having these large squares, small squares. Now this thing is paper speed. See whether the stylus which is moving on the ECG paper is following the golden principles that heart beats at 72 per minute. Actually, this is interpretation of 72 per minute. You just keep on bringing it down, it becomes 25 mm per second. What does it interpret? The one small box is equal, one small square is equal to 0.04 seconds, or in other word 40 millisecond. So if somebody ever asks you this question, that what does the small square represent, you would always be saying this is equal to 40 millisecond, or we also call it 1 mm. Then as we move ahead and we see the large square has 5 smallest boxes, so it will be equal to 200 milliseconds. So if I mark it here, it's equal to 200 milliseconds, this large square. Now if that stylus which is moving and forming waves, say I form it here, This is a QRS complex that comes back, then goes like that. Then this is a T wave. So you are seeing here that this is a P wave, then QRS complex, then there is a T wave, and then again the same thing will follow. A P wave, then QRS complex, then T wave. So this is based on that whole second strip is based on that phenomena that heart beats 72 per minute. I mean the RR difference between the two RR intervals, they should be after 0.8 seconds. So they should be after 0.8 because the cardiac cycle is of 0.8 seconds. So if a person is having an exact normal heart rate after every 0.8 seconds, and if I am talking about 0.8 second, how many boxes should be there? 1 large square, 2 large square, 3 large square, 4. So there should be 4 large square, 1, 2, 3 and 4. If there are 4 large squares, or in other words 20 small squares, we will say that a heart is beating exactly at 72 per minute, and between these two R's there are 4 large squares. So exactly if there are 4 large squares in a cardiac cycle, and if we take it as 1 second, so in 1 second there are 5 large squares, as simple as that. We want to calculate the rate now. What are the different formulas? The formulas are very easy to understand. The first one is rule of numbers. The rule of numbers tell you that if there is a 1 large square, there is just 1 large square between two RR complexes. Like there is a R here, say, and then next is 1, 2, 3, 4, 5, and then there is a R here. So how many boxes are there between the two R? 1 large square, or in other word 5 small square. The rate will be 300. And based on that simple principle, if there are 2 large squares, the rate is 150. 3 large squares, the rate is 100. 4 large squares, the rate is 75. 5 large squares, the rate is 60. And 6 large squares, the rate is 50. So it's as simple as that. You take hold of a ECG. Simple rule. You take hold of ECG paper. You see on the ECG paper, between two RR complexes, 5 small box, rate is 300. 10 small box, rate is 150. So just calculate like that. You want to exactly calculate the rate. Then there is another way out. Divide the number of 1500 divided by number of small squares between two R's. Like you need to calculate, if I want to exactly calculate the rate in this gentleman, 1 R is here and the other R is here. So I need to calculate the small squares between these two R's. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. 1500 divided by 18, and that will be the rate. As simple as that. So you want to calculate the exact rate? Just 1500 divided by number of small squares between two R's. 2 R's means 2 ventricular contractions, 2 QRS complex ventricular contractions, उसके बीच में आपको देखना है. So this is the exact way to calculate. You encounter a situation, you need to calculate the rate, but you encounter a situation where a patient is having irregular RR, then what will you do? Like you are in a situation where a person is having atrial fibrillation. In atrial fibrillation, the RR is irregular. So what will happen then? A person would be having a QRS complex, T wave, QRS complex, T wave, QRS complex, QRS complex, and then a QRS complex. Are these QRS complex equal to each other? Are these having coming at regular intervals? Answer is no. So then how we will calculate the rate? For this situation, what we'll do, we'll calculate it as number of R in 6 seconds, number of R in 6 seconds multiplied by 10, and you will calculate the rate. Number of R in 6 seconds, and if anybody asks you, what do you understand by 6 seconds? Now 1 second mean 5 large square, as I have told you earlier. 1 second mean 5 large square. 6 second means 30 large square. So you just need to calculate the number of R in total 6 seconds. Whatever the number is, say we calculate and it turns out to be 16 hours in 6 seconds. 16 hours in 6 seconds, you will multiply 16 with 10 and the sum will be 160. So this is for, so whenever you want to calculate the rate, there are two situations. One is RR regular. You will calculate it as rule of numbers, one principle, and the second is 1500 divided by number of small squares between two R's. So that's for the regular RR. And if RR is irregular, then irregular RR means RR interval is irregular. Then you will calculate as number of R in 6 seconds multiplied by 10. This is for atrial fibrillation and many other situations. Why it is important to have a look at the paper, that is the machine working at the speed of 25 mm per second, because on occasions it can be 50 mm per second. It means the stylus, like this R, after this R, if I make the speed 50 mm per second, then it will be doubled. This next R won't be coming here, it will be coming almost here. Why machine sometimes slow down the things? The machine itself automatically slow down the things because on occasions, if there are certain beats, there are certain subtle changes in ECG, like in the setting of, say, atrial flutter. The flutter waves are very close to each other. You just cannot interpret them. The machine will slow down the whole paper. So as this will slow down, there will be a gap between the flutter waves, and you can easily pick that after how much time the next flutter wave is coming. Like I'm giving you an example. If it is at normal speed, it's something like that. You double the speed, then it will be like that. So you would be able to calculate things the easy way. So please always focus that whether machine has switched it to 50 mm, because in case machine has switched it to 50 mm, what you are supposed to do? After calculating the rate, you will multiply it with 2. It has halved down the rate, na? So you are supposed to multiply it with 2. If I want to calculate, the machine has slowed down, this R was supposed to fall here, now it is falling here. After accumulating the data, after reading the ECG, I will multiply it with 2, as simple as that. Now next move on to, so this is all about the paper speed. The basic principles I have guided you clearly. 1, rule of numbers. 2, 1500 divided by number of small squares between two R's. 3, if RR interval is regular, then you are supposed to calculate it as total number of R in 6 seconds multiplied by 10. Now we move on to the voltage side. The voltage side, whenever you are looking at ECG, you would be finding something right at the start of the ECG, and that as the waves start, you would be finding something like that. So I make it here, you would be finding something like that. There would be a thing like that whenever you would be holding the paper, and then the waveform will start. What this thing tells you? This thing tells you about the vertical thing, tells you about the voltage. And how to calculate the voltage? 1 small square is equal to 0.1 millivolt. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. The 10 squares are equal to 1 millivolt. What is the standard voltage we set on the paper? So this is exactly this 1 millivolt voltage. The standard ECG is taken at 1 millivolt current. Please see whether the complexes which you are seeing are having this 1 millivolt current, because in certain situations the machine will automatically switch it to 0.5 millivolt. That has halved down those complexes. In other words, the voltage by the machine has been set to half. Why? Because in certain situations, what can happen? You are having a ECG strip that has 3 lines. Say in a person, there is one line of QRS complexes, then this is another line of QRS complexes, then another line. So this is how you are seeing the strip now. There is one long strip, and then there are machines which are having 3 strips or 4 strips. In the 4-strip, 3-strip machine, what can happen? If the complex is of large size, say the second line is having very large complexes, they would be touching the complexes of the first line, and they will merge. You won't be able to differentiate them together. So what a machine should do, so that you can clearly differentiate, this is the complex of the lower strip, the lower line, this line, and this is the complex. What the machine will do? It will halve the voltage. The complexes won't intermingle. Sometimes the machine will make it 0.25 millivolt. The 0.25 you have to now multiply it with 4. In order to know the exact voltage, you have to multiply it with 4. So please remember, never forget these things, because you would be missing the exact voltage. Then you won't be able to calculate what is the exact voltage in this person. You would be assuming that probably voltage is okay. I am now going to count the size of the complex based on this voltage, and lately you would come to know machine had turned the voltage to half. Machine had turned the voltage to 1/4. So these are the two things which machine does, either half or 1/4, just to avoid intermingling or mixing of the different QRS complexes. As we are focused on this voltage thing, exactly at the same point, I would like to guide you about the low voltage and high voltage ECG. Where this is part of the miscellaneous. I haven't mentioned it here. So low voltage and high voltage ECG. What is a normal voltage? And how you calculate the normal voltage? A normal voltage is calculated as count the total size of QRS complex, and when I am talking about the total size, this is what I mean, from this point to this point, right? Count the total size of 6 limb leads, QRS complex of 6 limb leads. So if you want to calculate the voltage, QRS complex size 6 limb leads. In all the 6 limb leads means lead number 1, lead number 2, lead number 3, then lead number AVF, lead number AVL, lead number AVR. Keep on counting it. Some of the lead will be like that, some of the lead will be that way, some of the lead will be that way. Just keep on counting. This is 1, 2, 3, 4. This is 1, 2, 3, 4 plus 3, 7. This is 1, 2, 3, 4, 5. 7 plus 5, 12. And same way, say 3 other leads are having the same size. So this would be like 4 plus 5, 9 plus 3, 12. If we are having 3 more leads exactly of the same size, it will be 24. So what you are supposed to get out of it? Count this size, and then after counting this QRS complex, say the answer comes out to be 24. It can be any answer. It can be 50, it can be 60, it can be 70. You just need to calculate the QRS complex size. Like this QRS complex is 1, 2, 3, 4, 5, 6, 7. Its size is 7. So just add all these QRS complexes. And whatever the sum is, divide it with 6, because we have calculated it in 6 leads. So we are going to measure the average. What is the average here? 4. This is 0.4. Take it as 0.4 because one small square is equal to 0.1 millivolt. So as we will calculate this QRS complexes, 24 divided by 6, this turns out to be 0.4. Now if this is 0.4 millivolt, now this is the average voltage of the 6 limb leads. Is it low? Is it high? Is it normal? In a normal, if a person is having normal voltage, it should be from 0.5 millivolt to 2 millivolt. So normal voltage is 0.5 millivolt to 2 millivolt. You are understanding? That's not thing is not that complex. Just focus on 6 limb leads, count the QRS size, and I have clearly told you that how to calculate the size. So this is almost 4 here, 5 here. You just keep on counting it. Add all the QRS complexes. Whatever the result is, divided with 6. And whatever the result comes, then mark the result. So here it was 4, so make it 0.4. If it was say 5, we would have made it as 0.5. If this is 0.5 millivolt to 2 millivolt, this is normal voltage. If this is less than that, this is low voltage ECG. If this is more than that, this is high voltage ECG. So in which situations we can have low voltage ECG? Answer is very simple. How the voltage is measured, we place the electrodes on the heart. If we bring something between the heart and those electrodes, like pericardial effusion, if a person is having massive pericardial effusion, will the current be reaching to those electrodes the same way? No. There will be low voltage. So if somebody asks you the question that can you tell us that which things would be leading to low voltage, your answer should be, sir, pericardial effusion. Any other example? Again, in tamponade, the problem is the same. This is, fluid. A person is very obese. Now there is a lot of fat between those electrodes which you are placing and between the heart. The heart is emitting current, but problem is there is a lot of fat. So patient would be having low voltage ECG. And high voltage ECG, it will be in those situations where the walls have become thickened. More stronger the wall of the heart is, more stronger current it will be dissipating, and as a result the voltage can be quite high. This is what I will be discussing lately as well. So to start with, paper speed, voltage, then move on to rate. I have told you about the rate. Then move on to rhythm. We have already discussed the arrhythmias. Then we have already discussed the axis. I have already told you about the thumb rule and how to calculate right left axis. PR interval, the normal PR interval, as we discussed in first degree, second degree and third degree block. In arrhythmias, we read that particular thing as well. Talking about the very important block, I would like to mention this block here. So we have gone through the topic of these blocks in arrhythmias: first degree, second degree, third degree. And as far as the right bundle branch block and left bundle branch block is concerned, we talked about those blocks in the arrhythmia section, but just to give you a very small basic principle, that if someone asks you what is there on the ECG, and you want to pick that right bundle branch block or left bundle branch block, what are the basic principles? One thing, blocks. So RBB, LBB. So the things are extreme right axis, extreme left axis. So usually there is extreme left axis in LBB. Not necessarily always there is extreme right axis, but that can be the exact opposite picture in this scenario. The second most important one, it is a prerequisite. The size of QRS complex will be more than 0.14 second, 140 millisecond. In other words, 1 box, 2 box, 3 box, 3.5. it will be more than 3.5 small square. So greater than 140 millisecond. Remember, 1 small square is equal to 1 mm is equal to 0.04 second, or in other words equal to 40 millisecond, right? So I am talking here that this should be greater than 140 millisecond. 3.5 small squares or more than that, right? So that's another important point of but the most important, most catching point is you see RSR pattern in V1, V2, and in the setting of LBB you see M pattern in V5 or V6, and you can catch these blocks. Just to give you an idea that what do you understand by this thing block. So we see here, this is heart, this is left atria, left atria, yes, this is right atria, the large size and the thickened one left ventricle, and relatively small size and the thin one right ventricle. From SA node is currently going to this point, AV node, bundle of phase. Where are the right bundle and left? This is the right bundle and this is the left bundle. Got it? SA node, AV node, bundle of phase, right bundle supplying to the right ventricle, left bundle supplying to the left ventricle. Now what is bundle branch block? You just block it. I mean, you are not supposed to cut it into half with a knife. So how these things get blocked? These things get blocked if somebody is having ischemia. Say the blood supply of this right bundle, the blood supply, the main conduction system is supplied with the right coronary artery. So there is a problem with the right coronary artery. There is a blockage. That right coronary artery will also be leading to what? Will also be leading to inferior wall. It can lead to right ventricular infarction. It can lead to posterior wall because it supplies in 80% of patient. It is the branch of the right coronary posterior branch which supply the posterior wall. So that can affect all those things. Same way it can affect the conduction system, or a person gets too old, his conduction system will be fibrosed. So in those situations, as the conduction system won't be working well, a person may suffer from some block. So talking about right bundle branch block, I just give you, we just block this thing. What will happen? And I draw here normal lead V1 in a person. This is a normal lead V1 in a person. In the setting of block, what will happen? In the setting of block, now the current is coming through the bundle of phase, not going to the right ventricle, but going to the, instead to the left ventricle. So the picture will be entirely changed, and now there will be a wave like that. There will be a wave like that because the current is now exactly opposite, going to the other direction. What will happen next? It will start falling. This wave will start falling. Why it will start falling? Because as there is ventricular depolarization, then ultimately the action potential settles down and this is going to come back. As it is going to come back, you call it S wave, and as it goes above, you call it R wave. So this would be the situation. What is happening here? Left ventricle contracted, it resulted in a waveform. Then there was repolarization, it was settling, it was coming down. Repolarization is after a while, and that is depicted by T wave. So as it was coming down to the baseline, what happened? As it reached to that point, through the Purkinje fibers of left ventricle, the current was dissipated to the right ventricle. The right ventricle didn't get its current through right bundle, but it got the current through those Purkinje fibers. Why in a normal person they do not get it through Purkinje fibers? Reason is they are relatively slow speed. This conduction system otherwise works quite fast. The fast thing dominates the slow one. But here this bundle is gone. Now the Purkinje fiber of the left ventricle resulted in contraction of the right ventricle. Again there is a contraction. And as ventricular contraction is there, a ventricular deeper, again there is a waveform, another wave. And then that will settle down again. So what happened here? There is a RSR pattern seen in lead V1 and V2. The same thing goes in left bundle branch block. Like in left bundle block patient, I make say a lead, this is lead V5. Now the current is not going to the left side. What will happen? There is a waveform because of the contraction of the right ventricle. As it was going down, it was supplied from the Purkinje fiber of right ventricle to the left ventricle this time. Again, there is a contraction and it comes back again. You call it M pattern. So M pattern in V5, V6, RSR pattern in V1, V2 is known as right bundle branch block or left bundle branch block. RSR pattern V1, V2, right bundle branch block. M pattern V5, V6, left bundle branch block. So remember these blocks, right? So that is all about these blocks. What next? Next is, as we studied the voltage, now I just wanted to tell you about the calculation of this voltage in relation to the ventricular hypertrophy criteria. On ECG, you can see a lot of things. Among those things, you always see the P wave and QRS complex. Probably we didn't write down the P wave here. Rate, rhythm, axis. Sorry, I forgot two things. Please. One is P wave. Another one is QRS complex. QRS complex. So whenever you read the ECG, this goes like that. Rate, rhythm, axis, P wave, QRS complex, PR interval, SC segment, T wave, Q wave, QT interval and miscellaneous. So one thing, P wave and QRS complex. So right now, I am focused towards QRX complex study. This is QRS complex. It can be narrow. It, as we discussed it in arrhythmias, it can be wide. What is the normal size of QRS complex? 0.08 to 0.1 second. Normal QRS size is 0.08 to 0.1 second. The two small boxes are equal to 0.08 seconds. In other words, 80 milliseconds. So if ever somebody asks you what is the size of normal QRS complex, you would be saying 80 millisecond to 100 millisecond. The book write down even the 100 to 120 is taken as intermediate size. This is not taken as broad complex. Got it? The broad QRS complex is 3 boxes or greater than that. 3 boxes means 120 millisecond. So if somebody asks you broad QRS complex, how will you define it? So you should say 120 milliseconds or greater is known as broad. The narrow is basically lesser than that. Normal QRS complex size, as I have highlighted you, it is 80 millisecond to 100 and 100 to 120 is considered this as intermediate. Now this QRS complex, first I wanted to guide you that how does it look like and what are its normal sizes. In a ECG, this is QRS complex. A wave which goes down is the septal depolarization wave. We call it Q wave. This is P wave. This is R. This is S. So this is QRS. This total is known as QRS complex. We just now move to through the right ventricular hypertrophy criteria and left ventricular hypertrophy criteria. LVH versus RVH on ECG. How will you know? The most important criteria to label somebody as having left ventricular hypertrophy or right ventricular hypertrophy is voltage criteria. So in all these situations, the most important one is voltage criteria. The number 2 is axis. The number 3 is strain pattern. There are few other things as well. Like we call it the peak of R wave size is more than 0.05 millisecond, but this would be confusing you a little bit. So these three things are enough. Remember voltage, remember axis, remember strain, what will happen in LVH and what will happen in RVH. So the most important criteria, if somebody ever asks you for LVH based on the voltage, is known as Sokolow-Lyon criteria. What is the Sokolow-Lyon criteria? The criteria states that the S wave in V5, V6 plus the most deep Q wave in V1, V2 if greater than 35. See, R wave in V5, V6, sorry, I spoken the S wave, R wave in V5 and V6 and S wave in V1, V2 greater than 35. So R wave in V5, V6 plus S wave in V1, V2 greater than 35, you label it as the patient is having left ventricular hypertrophy. There are other criterias like 2-3 other criterias which are quite commonly used. S wave in V1, V2 greater than 27 mm or R wave in V5, V6 greater than 27 mm. Another criteria, AVL greater than 11 mm, R wave in AVL greater than 11 mm, S wave, any lead having S wave more than 27 mm or any R wave in V5, V6 more than 27 mm. But the most important one, you sum up the R wave in V5, V6 and the largest R wave. Like you see these two are say V5 and V6. Now one of the lead is having this R wave, other one is having this R wave. Which I will take? The one which is larger. I will calculate this R wave, and if somebody is having the S wave, say this is the S wave, this is P QRS complex, and this is S wave, right? So this S wave is the downward wave, and I am again drawing another lead. Here the S wave is like that. Now which one is deep one? This one. So if this is lead V1 and this is lead V2, this is the deep S wave. I will calculate the deepest S wave in the longest, highest in the form of amplitude R wave. And if two things, you add them and the sum is more than 35, you call it LVH criteria, Sokolow-Lyon criteria, voltage criteria for left ventricular hypertrophy. If we want to see the right ventricular hypertrophy criteria, it goes like R wave in V1, R wave in V1 greater than 7 mm, or in other words, S wave in V5, V6 greater than 7 mm. I am using the word mm. You understand the mm? One small box, one small square is equal to 1 mm, 2 mm, 3 mm, 4 mm, 5 mm, 6 mm, 7 mm. So if somebody is having R wave in lead number V1, V2 greater than 7 mm or S wave in V5, V6 greater than 7 mm, that can be taken as right ventricular hypertrophy criteria. Axis. I already told you this is the normal QRS complex. This is the normal cardiac axis direction. As we draw it, as I guided you earlier, if a person is having thickening of this left ventricle, what will happen? More thicker the ventricle is, more it will pull the axis towards its side. So it will be like that. This will go that way. I mean, axis will take that direction. So in the setting of left ventricular hypertrophy, where it will go? Left axis. And in the setting of right ventricular hypertrophy, where it will go? Right axis. So that is the second criteria. And then strain. I already told you while we were discussing the T waves that as say the pressure goes high in the heart chamber and there is a high pressure state within the ventricular chambers, the high pressure state are usually three: aortic stenosis, hypertrophic obstructive cardiomyopathy, and hypertensive heart disease. In these settings, there would be a lot of pressure built in inside the ventricular chambers that will result ultimately the pressure, continuous pressure will result in increase of heart size, and the ventricular wall on that side will be more thickened. Myotrophic myocytes hypertrophy is there. Those cells got hypertrophied, and that wall of the heart will be thicker than the rest. That wall will ultimately lead to that kind of a strain pattern. The maximum strain is taken by the lateral wall of the heart. Lateral wall of left ventricle take the maximum strain. So what you will get in those lateral wall leads, by now you know the lateral wall leads are 1 AVL V5 V6. So in 1 AVL V5 V6 you would be finding this would be kind of a ST, this would be kind of T wave. Normal T wave is, this is normal T wave. T wave say inverted is there. This is a normal symmetrical T wave. In another situation you see T wave like that. So see the difference. This is a symmetrical T wave. This is asymmetrical. If I draw a line here, so you see there is no symmetry. This is asymmetrical T wave. So if you see asymmetrical T wave inversion, inverted asymmetrical T wave in lateral lead 1 AVL V5 V6, we call it strain pattern. So that is the third criteria. If ever somebody asks you that how would you judge on ECG that this is LVH, you would be saying, sir, I would like to mention you the voltage criteria, and additionally I would like to mention you 1-2 more things. And 1-2 more things are, one is strain pattern, one is axis. Based on all those things collectively, you label the person as having left ventricular hypertrophy. And in right ventricular, there would be right ventricular strain. Right ventricular strain. Can somebody tell me where would be that strain? The right ventricular strain on ECG in chest leads. Which chest leads we are supposed to look for? V1, V2. In V1, V2, if you find the strain pattern, again these sort of asymmetrical T waves, we will label it as right ventricular strain. So we are over with left ventricular hypertrophy criterias and right ventricular hypertrophy criterias. We next move on to P wave. P wave on ECG represents atrial depolarization. Whenever you are going to comment on P wave, comment basically in two leads, either in lead number 2. Lead number 2 is also known as rhythm lead. So either focus on that lead number 2. So what is the criteria of, if you want to know about any abnormality, you must always be knowing about the normality first. So what is a normal P wave? A normal P wave must not be, I'm talking about lead number 2 here. A normal P wave should not be broader than 2.5. Broader than 2.5. Peaked 2.5. It should be lesser, its amplitude should be less than 2.5. Its breadth should be less than 2.5. As simple as that. So in a person, if I am drawing this P wave and this P wave is like that, this is broader. If I draw P wave like that, this is taller. So a P wave should be less than 2.5 height, less than 2.5 means 2.5 small squares, small boxes or squares, right? Now what are the abnormalities then? The abnormalities are one is P pulmonale, one is M mitral. How you will pick this on ECG? We will focus on one lead number 2 and second lead number V1. So we will be focusing on these two leads. So I'll be drawing these leads for you. I draw these leads here. So we are going to now see the changes we would be seeing in lead number 2. What will happen if a person is having M mitral? The P wave would look like M mitral is greater than 2.5 small squares wide and usually having a notch. We call it this becomes kind of M. We call it M mitral. In the setting of mitral stenosis, what will happen? We would be having a person with this kind of ECG. After seeing this ECG, would be saying that this patient is having mitral stenosis. The stenosis has led to left atrial hypertrophy because there is a stenosis in the mitral valve. Now the blood cannot go well to the left ventricle. And if it is not going well to the left ventricle, the pressure will be on the left atria. This will get enlarged. How you would be seeing that enlarged atria on ECG? Because in ECG, the atria are represented by P wave. So we would be focusing on P waves. And what would be the changes in the P wave in the setting of mitral stenosis, M mitral? This will be broad and bifid. You call it broad and bifid. The second situation is that again a person is having abnormality in the P wave, but this time this is like that. This P wave is that way. Now this would be seen in the setting of P pulmonale, like a person is having high pulmonary artery pressure due to any abnormality of the lung, say. I mean, if patient is having interstitial lung disease, a person can have pulmonary hypertension primary or secondary. So this pulmonary hypertension will lead to what? Back pressure. Where will be the back pressure? On the right atria. And how right atria it is represented by? Again, P wave would be depicting us about the atria. And if this is peaked like that, we will call it P pulmonale. So this is peaked and we call it P pulmonale. Now we want to see the same two things in lead number V1. So either these P waves are seen in lead number 2 or V1. In V1, the situation is a bit different. In V1, we would be focusing on leads that way. In lead V1, the P wave is having two components. This is QRS complex. Just focus on P wave. This is above the baseline. That one is below the baseline. The first component always represent the left atria. Right atria, sorry. The first component always represent the right atria. This is always represent right atria. And the second component, which is below the baseline, that is represented by that represents the left atria. Now, when we will consider it abnormal, if this right atrial component of P wave is more than one small square, deep or having more breadth or more height. In this situation, obviously it is above the baseline. We will take it as if it is having height of more than one small box or breadth more than one small box, this is abnormal. Got it? You would be seeing the P wave in lead V1. The lead V1 having a P wave with two components. One is above the baseline and the second one is below the baseline. The first one, which is above the baseline, represent right atria. The second one below the baseline represent left atria. The criteria goes the same way in both situations. If that component which is above the baseline, the first one, is more than one small box peak or more height, having height, or more than one small box breadth, this is known as right atrial hypertrophy. And same way, if the lower component the second component is more than 1 mm deep, 1 mm mean 1 small square, or more than 1 mm breadth, having more than 1 mm breadth, this is again abnormal, and this would represent left atrial hypertrophy. So please remember, this is how you see P wave, you see the hypertrophy of the P wave, you see P pulmonale and M mitral. So in this situation, the first component in a person that would be suggesting again the M mitral in this patient would be like that. That patient would be having this second component more deeper or more wider. And the person with peak P wave, P pulmonale, would be having this first component either more than 1 mm broader or having more than 1 mm height. So that's about ECG, QRS complexes, PR interval, blocks, ST segment. We have already gone through the last few things, the last 10 minutes. Electrolyte imbalance. How would you be assessing the electrolyte imbalance? Again, you are not supposed to focus on all kind of electrolyte imbalances. We are just mainly concerned with potassium here, and I would also be telling you a little bit about the calcium changes. Calcium changes are not many, but as far as the potassium changes are concerned, they are classically 3 to 4 potassium changes. The first, as the potassium keeps on going low, you keep on seeing, based on that low potassium, you keep seeing different changes. The first thing is flattening of T waves. So that's usually the first thing which appears. The second thing is ST segment depression. The third thing is then U wave formation. U wave formation. And the fourth thing, usually these things are combined together, is QT prolongation. How you would see these changes on ECG? Like I draw ECG here. This is P wave, QRS complex. This is all normal. This person developed hypokalemia. The first two changes will look like that. Now the P wave will turn flattened. Sorry. The ST segment has bit depressed and the T wave had turned flattened. Now that is a normal person ECG and that is an abnormal one. A person is having decreased potassium, the T wave is flattening now, the ST segment is T wave is flattening and ST segment is lowering down, right? What happens next? U wave formation. What is U wave? A U wave is another T wave. Its name is U wave. You can have, a kind of a wrong concept that a U would be there, but remember, this is not U, this is another T. QRS complex, P wave, QRS complex, T wave, another T wave, and then P wave, QRS complex, T wave. So there are two T waves here. The second one is known as U wave in the setting of hypokalemia, and in many other conditions you can have these U waves. Now, this is your task. Just go through the literature. It's not necessarily the only hypokalemia, but at least you should be knowing. You should be knowing that in hypokalemia, if U waves are there, the potassium is quite low. It is usually lower than 2. So the potassium levels are very classically guided by the ECG changes. So U wave is another T wave with the same direction. Remember, there can be rare inverted U waves. There can be rare inverted U waves. Those are in few other things, not necessarily supposed to be mentioned here. Can you have normal U waves? Yes, normal U waves are there as well. A normal U wave, normal U waves are quite common. A person is having T wave and then there is a U wave. Are you seeing something unusual here? There is another T wave and then there is a P wave. Remember, the normal U waves are having amplitude 25% or lesser than that of the normal T wave. Got it? If T wave is of that amplitude, the normal U wave will be having amplitude of 25% lesser than the normal T wave. So that you should also know, so that you will not be confusing it with that U wave present in the setting of hypokalemia. If it is in the presence of hypokalemia, the U wave is almost of same amplitude. So that's the total story. The last thing is prolongation of QT interval. In the setting of hypokalemia, a normal person is having 40 millisecond QT. If QT is greater than 40 millisecond, means 44 millisecond or more than that, we call it prolonged QT interval. I mean, few other things can be there in ECG, but this is what I wanted to highlight here. You can read WPW, you can read few other things. Those will fall in the miscellaneous category, but this is what we were interested in. So just summarizing, whenever you guys are looking at ECG, always focus on paper speed first, then voltage, rate, rhythm, axis, P waves, QRS complex, PR interval, blocks, ST segment, T wave, Q wave, QT interval, and then in the miscellaneous setting, you can find different other things as well. So this is all about the ECG, the basic principles, whatever at your level you wanted to know, this is sufficient. Thank you very much.